Hi, everybody. Welcome to IB Debrief. Thank you so much for being here today. We have a lot of great cases and a really wonderful panel. So we're going to get started. So as you know, this program is funded by Pfizer, and we're going to start with a primer on perianal disease with Dr. Wong.
Good evening, everyone. Thanks for having me. Today's hot topic is perianal fistulizing Crohn's disease, a topic that I have clinical and research focus in. So 20% of your patients with Crohn's disease will have perianal manifestations over the life course of their disease. As you may well know, 2/3 of these patients will undergo perianal surgeries, primarily EUAs or exams under anesthesia with the colorectal surgeons. And ultimately, 6% will require major abdominal surgery, primarily fecal diversions, right, with ostomies, completion proctectomies, and some. So patients will present with either simple or complex fistulas. We mostly will be dealing with complex fistulae because they are very common in our patients, but also simple fistulae don't involve the deeper tissues or the sphincter, and they tend to be a bit easier to heal. Your main symptoms are going to be pain and drainage from these lesions, and patients tend to have poor outcomes and increase in hospitalization, surgeries, medication changes. Disease will often progress despite all of this. There's a high rate of recurrence. Patients who heal, 40% of them will probably recur at some point. There's a great impairment in quality of life, and it's actually an independent predictor of work disability. So I've arranged this today's primer to be a top 10, which I think actually covers everything that you probably need to know about perianal fistulizing Crohn's disease. So first one is, do screen for luminal Crohn's disease in patients who present with complex perianal fistula. So perianal fistula and luminal disease, the majority of your patients will have both. They coexist, and it's highly associated particularly with disease in the rectum. So they will either present both at the same time at diagnosis or luminal disease first, followed by perianal fistula. Side note here, skin tags and fissures can predate perianal fistula, so please look at your patient's bottoms when you diagnose them. In general, it's thought to be that about 10% of patients will present as first manifestation with perianal fistula alone. Some of these patients ultimately at diagnosis or along the way will develop luminal disease. Overall, it's thought that 5% of these patients will persist as only having perianal fistula without luminal inflammation. These are the isolated perianal disease patients. We actually don't know a lot about them. We actually don't even have full agreement on how to diagnose these patients. You can biopsy their fistula, but only a minority will have granulomas. And we tend to treat them as Crohn's disease and hit them with an anti-TNF. But the truth of the matter is the jury's a bit out as to how we should treat them. There's actually a paper from Canada that states that these patients may have a lower response to anti-TNF. So these are tough patients, but they exist. So when you evaluate your patients, do please ask them about their symptoms and acknowledge their symptoms. It's very important to them because they're living with this in their daily lives. So when you're evaluating them, of course, first you're going to ask them about pain, drainage, restriction of activity. Can you walk? Can you sit? Can you stand? Can you sleep comfortably? And sexual activity and bowel urgency is really important. For your objective exam, again, like I said, please look at their bottom sides. You'll do your ileocolonoscopy with biopsies. We have caught patients who had perianal fistula, endoscopically look normal, and lo and behold, their TI biopsies show chronic inflammation. So you really need to get those biopsies. It's not good enough to just look. And then MRI is our mainstay of evaluation. All right, now you have your patient who you think has PFCD. From day one up front, do set goals and expectations, do recommend psychosocial support. In fact, this latter point was the one thing that an international fistula consortium agreed upon as the one thing that you should do, or one of the things you should do, I should say. So what do I tell my patients? There are diverse outcomes. We may or may not be able to close the fistula. However, our goal is to control your symptoms and help you maintain your quality of life so you can go about your daily life. This will generally entail combined medical and surgical management. So the short-term goals, which also transmit to long-term goals, are controlling symptoms, preserving mental and physical quality of life. And then in the long term, of course, we're trying to prevent recurrence and progression of disease, perianal fistula in particular, and preserve continence, right? This is an area that involves anal sphincters. So now we're going to treat a patient. What medications are we going to give them, and what surgeries are we going to offer them? Do give antibiotics to decrease drainage and control infection, but don't give them to heal the fistula. So step number one is always make sure if there's any perianal sepsis that you're controlling it. This involves surgery with abscess drainage, ceton placements, and antibiotics. And they do wonders for that and also for drainage symptoms, but they don't close them. So how do we close the fistula, at least medically? Infliximab, right? And that leads me to my next point. Do give infliximab as first line where possible, and do consider combination therapy or at least maximize therapy. The reason is that infliximab remains to this day the one randomized controlled trial proven medication to close fistula. None of the other agents that we know of so far have done that. And so you'll want to maximize therapy and optimize it depending on how patients do. And as I walk you through this, you're going to re-examine and look for pain and drainage, look for proctitis or not. And so, what do you give after an anti-TNF? We don't know. Do be on the lookout, therefore, for efficacy data upcoming, hopefully in the next year or two, on newer agents. These are the ECHO guidelines from a couple of years ago. And as you can see, infliximab is number one. There may be utility of using adalimumab. Not enough evidence for immunomodulators, but please do target levels. We go for levels 20 and greater in these patients. What do you give if that fails? Systematic review and meta-analysis has shown that maybe ustekinumab is, has a little bit of efficacy, but there really is no data. It's insufficient for both Stelara and Entyvio. Rinvoq has looked very promising in post-hoc data from the clinical trials. So this may be an up-and-coming agent that we can add to our armamentarium. And just be reminded that, we all love the Skyrizi, but we actually don't have data, to my knowledge, on its efficacy in perianal fistula healing. And again, the rest of these things don't work. So you've got your patient, you've given them Remicade. Some patients will heal and improve, and you may even consider ceton withdrawal or closure. So you really need to talk to your surgeon, because your surgeon is part of every single one of these steps, or at least read their notes. And don't hesitate to refer to a dedicated IBD surgeon at a tertiary center. And the reason I say this is that these are different from your bread and butter cryptoglandular fistulas that the surgeons will be seeing on a daily basis. And so you need an IBD surgeon or someone who's dedicated to IBD to manage these patients. We've seen a lot of patients who've had reparative attempts who shouldn't have. We've seen patients with cutting cetons who shouldn't have had them. So, low threshold to, send them over. And then finally, they're going to be part of your conversation for your severe disease patients who progress and need diversions or proctectomies. But don't promise reconnection in these patients, because the majority of them will not be reconnected. Please remember that. We've had a lot of patients who have thought that they might be, and they aren't. A meta-analysis of 1,500 patients with perianal or distal colonic disease showed that while 50% had response after diversion, restoration of continuity was only attempted in 37%, and overall 24% were restored successfully, but 26% required rediversion. And ultimately 31% of patients required completion proctectomy. And these patients actually have perineal wound healing issues, at least the perineal fistulae patients do. In a multi-center retrospective that was led by David Sacker here at Sinai, of patients who underwent temporary fecal diversion, the perianal patients, only 6% were able to undergo successful restoration. So it's really a minority of patients. So I'll just briefly go through and give you my last point. So do screen for luminal disease and take those biopsies in patients who present with complex perianal fistula. Do ask patients about their symptoms and set goals and expectations and offer them mental health support, because it really impacts their daily lives. For medications, do give antibiotics, but that's for drainage and for abscesses. And infliximab reigns supreme to this day, so please do give it and target high levels. be on the lookout for some up-and-coming data. I think new agents will hopefully, prove to have some efficacy. Communicate with your surgeon and set realistic expectations, particularly with regards to diversions. Lastly, these patients are at a small but a real risk of perianal PFCD-associated anal, rectal, and fistula cancers. Tends to occur, we think, there's not enough data, but tends to occur in patients with long-standing disease. So even if someone has quiescent disease, don't ignore their bottom side. It has happened over time, asymptomatic patients, but also patients who have progressive or continuing persistent perianal symptoms. The symptoms are nonspecific. They need to be screened and evaluated for cancer. Thank you.
Cindy, that was a wonderful review, and I know you were trying to keep it to 10 commandments because we're on the Mount Sinai, but I would add an 11. Always consider these patients for clinical trials. If there's a clinical trial going on, because frankly, other than infliximab, nothing works.
Yeah.
So keep that in mind.
Yes, and we do have some ongoing clinical trials, including here, for sure, because we need more.
Dr.
What's the status of stem cell installation?
Great question. I probably should have added a note about that. So stem cell therapies wherein mesenchymal stem cells are injected into the fistula, they're actually online. They're in use in Europe and parts of Asia. There was a product by Takeda that was,
The same.
the same product that's in use there was also being trialed here in the U.S. Unfortunately, late last year, we received notice that that trial actually didn't reach significance. There was no improvement over placebo in that study.
And explain why.
If I may.
We think, right, so we're not actually sure if the placebo is a true placebo, right? So in those patients, first of all, they were very carefully chosen patients in terms of their disease, but also that involved a curettage and a stitch, which isn't necessarily standard of care for all surgeons. So we're actually very interested to know if maybe we should be doing that more often.
The placebo effect was already very high in the
It's like 60%.
European trials that we did several years ago. It's even higher. So you may imagine that the technique of the surgeons have even improved. They are more doing curettage, more carefully closing the internal opening.
Yeah.
So it's not really a placebo group.
Exactly.
It's,
I will also
Right.
say I participated in some of these, and
Yeah.
you can very much tell what is placebo and what's not. It's like it's saline, it's clear, versus a stem cell is a little turbid quality to it.
so in that case, it should the study
It's
should
just,
have
it's
worked.
just, it's just funny that
Right, it
it's
should have
randomized
worked.
control. I'm like,
But whatever, I mean, the bottom line is that it will not be approved in the US.
Right.
This formulation, but there are, I believe, other companies that are
There
trying
are other
this.
companies and there are other clinical trials for autologous stem cells at other institutions, yeah.
We're gonna do one more question, then we're gonna move on to cases.
Okay. Great talk. You did not issue a commandment, so I'd appreciate your opinion. Under what circumstances you're comfortable with vaginal delivery of perianal disease?
Under very few circumstances overall. I think it depends on the case, right, and the severity of disease, for example, simple versus complex fistulae. But for most patients, we have a serious talk with them when they come to that point that they should consider cesarean section. The recurrence rate is so high and the pressure in that area is just a bit dangerous.
It's a very complicated question.
But it's a complicated
In Mount Sinai, yes. We have patients who have 12 deliveries that you can't do C-sections on. So it also, you have to customize it to your customer. But that is a good question, and maybe we can elaborate that more.
should.
Yes.